Hello everyone, my name is Nathan Graff, and for my final project I wanted to research and identify risk factors for coronary heart disease, as well as finding the best predictive model. So coronary heart disease is actually the leading cause of death in the United States, approximately accounting for 1 in 4 deaths here. That results in approximately 1 death for every 36 seconds as a result of coronary heart disease. So obviously this is a fairly pressing issue. I work per diem as an analyst for a hospice in Rhode Island, and without divulging too much information, the number of patients we see with coronary heart disease is quite staggering, and that was mainly the driving force that led me to this project. So what exactly is coronary heart disease? So coronary heart disease is a diagnosis in which the arteries of the heart can no longer deliver the necessary oxygen-rich blood to the heart. It's often a result of substantial buildup of plaque in the arteries. Furthermore, coronary heart disease can lead to ailments like chronic chest pain, or more severely like heart attack or sudden cardiac arrest. Being such a rampant issue, it's unsurprising that coronary heart disease is often studied. One of the most famous and often cited studies is the Framingham Heart Study. This longitudinal analysis started in 1948 in the town of Framingham, Massachusetts, when the town received funding by the National Heart Institute, which is now known by the name National Heart, Lung, and Blood Institute. This study focused on the sample of men and women from the town, now called the original cohort. There have since been 4 other spin-off cohorts, 2 of which follow the second and third generation offspring of the original cohort, and 2 are focused on more ethnically diverse groups. I found the data on Kaggle. The original person who published the dataset did not identify which cohort the data came from, but judging on attributes like the sample size and age of the participants, the data most likely comes from a point in time of the original cohort. Data from the Framingham study is often cited in many publications. These publications are often looking at predictive modeling for coronary heart disease or using statistical analysis to identify key risk factors. Some commonly identified risk factors of coronary heart disease include high amounts of low-density lipoprotein cholesterol, low amounts of high-density lipoprotein cholesterol, high blood pressure, family history, diabetes, smoking, age, and being male. Given the aforementioned risk factors, there are several variables within the dataset that are either one-to-one measures of those aforementioned factors or are highly related. Those factors include systolic blood pressure, diastolic blood pressure, whether the participant suffers from hypertension, total cholesterol, whether the patient suffers from diabetes, glucose, whether the patient is an active smoker, the estimated number of cigarettes smoked per day, sex of the patient, and finally age of the patient. So that leads me to the objectives of the project. I first wanted to identify which variables are found to be significant in predicting coronary heart disease. Specifically wanted to see which of those variables among the ones just mentioned are significant predictors. Additionally, I wanted to construct and compare multiple models for prediction and then compare their predictive accuracies. Before we get into the actual statistical methods, I thought it would be best to go over the descriptive analysis of the data. We see here the stacked bar chart featuring the frequency of negative and positive diagnosis of coronary heart disease within the dataset. It's quite obvious that the negative diagnosis occurs much more commonly as opposed to the positive diagnosis. We can also infer that males do test positive for coronary heart disease more frequently than females within the dataset. Next, we can take a look at the cholesterol levels. It appears that the mean cholesterol for those who suffer from coronary heart disease is elevated compared to those who do not suffer from coronary heart disease. And this trend continues for the blood pressure. For both systolic and diastolic blood pressure, there is an increase for those who suffer from coronary heart disease as opposed to those who do not. This trend continues for glucose as well as the cigarette consumption, and finally there is a distinct difference between the age between those who suffer from coronary heart disease and those who do not. Next, we can discuss the methods used within the project. So first, there was a sizable amount of missing data. About 14% of the data were not complete observations. I wanted to compare the predictive accuracy using a testing data set, so I was already losing many observations to that partitioning. So in order to preserve as many samples as possible, I implemented a predictive mean matching multiple imputation method to impute the missing values. Once that was done, I modeled my data. The first was an ordinary logistic regression model. I would use the purposeful selection method as mentioned in the textbook to find a reduced model. That model would be the basis of my interpretations, but I would go on to construct 3 more models to see if I could gain any more predictive accuracy under the methods. Those consisted of lasso logistic regression and 2 generalized additive models. Lastly, I'd feed the models data from a testing dataset to check their model accuracy and compare the ROC curves, specifically the area under the curve for each method. So the first model created was a logistic regression model using all available variables as covariates. Here, there are only several predictors that are significant, that being male, age, cigarettes per day, stroke, hypertension, systolic blood pressure, and glucose. Given that many of the predictors were insignificant, I suspected that there existed some strong multicollinearity between the variables, and also given the large number of predictors, I wanted to pare down the model. Featured here is the reduced model, given by the purposeful selection procedure. It isn't any different from the backward selection process, as it obviously first implements the backward selection, and then that reduced model is then constructed with interaction terms. I performed a likelihood ratio test comparing the second-order interaction model with the simplified model, and the result was a p-value of 0.06, so I went with the simplified model. Furthermore, we see here at the bottom of the slide the regression model. We see that the predictors found most significant were that of sex, age, cigarettes per day, stroke, hypertension, systolic blood pressure, and glucose. Most of those variables align with the commonly accepted risk factors. The only variable that isn't denoted as a risk factor is the history of stroke. I suspect that history of stroke might be a confounding variable, as strokes and coronary heart disease have seemingly similar risk factors, although more domain knowledge is necessary to fully rule it out. As we all know, with the model we can make important inferences about the data. For instance, exponentiating any of the estimated coefficients yields the multiplicative effect of the odds of coronary heart disease given the variable. Additionally, if we take the inverse logit of the equation, we can derive the estimated probability of coronary heart disease for a subject. That said, I had done exactly that and compared the predictive results of the full model and the reduced model. Here, we see the ROC curves for the 2 models. The left is the full model and the right is the reduced model. We can see that the model selection procedure yielded us a slight benefit to the prediction accuracy by increasing the area under the curve of the original 0.710 to 0.712, a very minimal increase. Since the predictive results were not astounding, I sought to curate other models. The first was another model selection procedure, specifically lasso regression. Although the results were very similar, the lasso regression model identified the most important predictors were those of the same predictors found in the purposeful selection method. Despite that, the shrinkage techniques seemed to provide more accurate estimates for the coefficients, as the area under the curve increased from 0.712 to 0.713, again, a very minimal increase in predictive accuracy. The last 2 models were generalized additive models. The first one featured all remaining variables as covariates and had smoothing applied to all numeric variables. This model had the worst performance so far compared to the others, so I had sought to pare down the model using model selection procedures. The next model was another generalized additive model. However, this model was the result of a backward selection process comparing the AIC score. This model identified the best predictors as sex, age, cigarettes per day, stroke, hypertension, cholesterol, systolic blood pressure, diastolic blood pressure, glucose, and then had smoothing applied to just age and diastolic blood pressure. This model was the best performing, but again, a very marginal improvement from the previous frontrunner, lasso regression. This model featured an area under the curve of 0.714, just beating out the lasso regression model by 0.001. Unfortunately, it's a bit upsetting that I did not see more of a substantial improvement in the predictive accuracy of those models as they became more complex. I'm convinced that the predictive accuracy gained from those more complex models is not entirely worth the loss of accessibility or the interpretability. For instance, with the original reduced model, all that was necessary rather is transforming the coefficient to gain inference of the effect of the parameter. That same ease of use is simply just not available for models like the generalized additive model. For instance, if we look here at the confusion matrix, or matrices rather, on the left is the reduced model and the right is the reduced GAM model, both with a cutoff of 0.5. We can see from the matrices here that both models have about an 85.5% accuracy in diagnosing the true positives and true negatives. This strengthens the idea that the complexity added with the GAM model is not worth the trade-off for accessibility and interpretability when compared to the ordinary logistic regression model. So in conclusion, it seems that the reduced logistic regression model is suffice for prediction and interpretation. It was exciting to see that the reduced logistic regression model featured significant predictors that coincided with what prior literature had suggested, those being the variables typically related to the risk factors of coronary heart disease. And lastly, if I continue to work on this project, I'll most likely try to find another dataset. This dataset obviously worked well for this project because it was a point-in-time dataset. However, the original Framingham study obviously is longitudinal, so something like that might gain better inferences and have a better predictive model. So with something like that, I'd probably investigate something like a generalized linear mixed effect model, but obviously more research will have to be conducted there. But in conclusion, I'm fairly happy with many of the models within this project, and they seem fairly satisfactory for predicting coronary heart disease. So this concludes my final project for categorical data analysis. If you have any questions relating to the project, please feel free to email me. My email is present on screen here, and I'd be happy to respond to any emails. And thank you very much for watching. Goodbye.